Yeah, Tomasa, will you come and help in the chair here?
Okay, you can just, you need the hand one?
Oh, it's
Just get near. Okay, you can stop.
I think they just sort of sit this.
I'm glad to have
Right.
you.
Thank you very much for
I'm delighted with
the time and for the invite. I just want to share with you something about the aortic arch treatment, and it's mainly to discuss the evolution of how treatment can start somewhere and move to be somewhere after a few years, and also show you some technique changes and improvement. And the morale of this is obviously to talk about how surgical technology and can change and how we can change our technique based on our patient demands. First, we have to acknowledge that these conditions are only for a selective group of patients who either have a high risk option for open surgery or they were turned down for open surgery. So it's not for all patients, it's only for a very small subset. And also important to highlight the number of these patients who treated is small. So in 2014, we took about 38 patients and challenging mortality and complication, etc. Then when we looked at more of selective group, the type A dissection, which are the better group to have this treatment, those who had a previous type A dissection, graft in the ascending, and they have an aneurysmal disease further down. And even that, when we look at this publication we were part of, and when we look at the number of 70 patients out of a number of centers, that's in 2018. So the numbers are very small, and this treatment is still evolving in terms of option. So just to summarize it in general, so we're talking about placing endograft in the aortic arch. This endograft is delivered through a delivery system with a specific deployment sequence. This endograft has two branches, opening here and opening here, and they are tunnel if we look at them from inside. And these branches supposed to go and supply the blood supply to the innominate artery and left carotid, and I will talk further about the left subclavian. And the concept is, and this is a beautiful picture here at the top left, hand drawn by my colleague Tommaso Donati when he was with us at St. Thomas's, and there are the carotid subclavian bypass first, then we used to go and implant the arch branch and connect the innominate artery with a bridging stent, and then the carotid artery with a bridging stent. So that was a concept, and the aim to achieve this solution, which you see here, saccular aneurysm in the aortic arch, graft in the ascending, branch to the innominate, branch to the left carotid. We used to come do the left subclavian, carotid left subclavian bypass first, come through it, go down, and cannulate the carotid. That was a bit of staged procedure. Then in 2018, things improved. We were able to do endograft with the three branches. So the left subclavian does not require bypass. Great thing. Better option, one-stage treatment for the patient, and less comorbidity and complexity. This is what we have here. We have a graft for the left subclavian retrograde. We indeed can have antegrade as well, but we no longer need carotid subclavian bypass. And we have that option, graft with three branches. But then we still have the challenge of the access. To get to the innominate and to the left carotid, we either have to get bilateral carotid access or right axillary and left carotid access. So two incision, heavily anticoagulated patients, and some comorbidity, and these patients normally, as I mentioned at the beginning, turn down for surgery, so they don't tolerate any minor complication. So we have seen challenges. This one patient who had a bilateral carotid cut down and had a carotid hematoma because of the platelets were low, the anticoagulation is high, etc., stayed longer in ITU, required re-exploration. We all know what re-exploration of the carotid artery means. eventually made it, but was long recovery. So we thought, do we need to do carotid cut down to cannulate the left carotid branch and to cannulate the innominator branch and place our bridging stent? Is there another way around it? So we thought the percutaneous access is a good option. So the percutaneous access to the right axillary artery is established. We use 2 prog lines to access the axillary artery under ultrasound guidance, insert 12 French dry seal, cannulate the innominator artery as you see, innominator branch as you see here with the markers, and place a bridging stent, in this case, gore limb. What about the left carotid? The left carotid branch, we don't want to do left carotid cut down, so the option is we have a rerouted access for the left subclavian branch, through it, coming out here, going back into the carotid again, and having a preloaded catheter. How do you use that? If you imagine this preloaded catheter is the green, so that's in the graft, outside the graft, keep outside the graft, come down inside the carotid artery. We have a wire here. Come again with the yellow from down, up, snare, catch this wire and establish through and through access. And that through and through allow us to place a large sheath, either steerable or non-steerable, and side puncture it and cannulate the carotid artery here as you see. So we're coming from here, rotating up, again up to the carotid and placing bridging stent. So that's a concept, and the concept is here, optimizing technique within a short time. So if we look in 2016, the number of cases globally very small. So the number of our cases since 2016 is 22 cases. We started with 2 inner branches, then moved to 3 inner branches. We treated patients with a previous metallic valve, and our last 8 cases were totally percutaneous. Those are currently in submission with another center from Paris for under review. We had 1 death, we had 2 strokes, and we had 1 case of intraoperative bleeding. The summary, the technology can evolve and can improve, and I'll share with you in the last minute 1 case example of 55-year-old man who's a smoker, previous type A dissection, multiple complication, mainly related to his bowel ischemia, abdominal wall. So in summary, he was not suitable for any further open surgery, and he didn't want to. They had a metallic valve, and this is this patient, which you see the chronic dissection, you see the aneurysm here, and you see the mechanical valve here. So for this patient, the option was in a total endovascular repair with the aortic arch branch here, and also candy plug to plug the false lumen. And the process was crossing the mechanic valve, which is a case which required collaboration with our cardiac surgeon, cardiologist, cross the metallic valve safely, and then place the arch branch. We did the cannulation percutaneously as I described before. We also cannulated the false lumen here, you see it distally, and the final results, we have a plug here, we have a flow, and we have no back bleed. I think I might need to borrow another 10 seconds. So this is the final outcome, and again the message is how treatment can evolve. It was not possible before to cross metallic valve, to do percutaneous treatment for this condition. And that means early recovery for these patients and less complication. So in summary, it's evolving endovascular therapy. It's still small, but it's evolving like everything. When it starts small and it evolves. We were able, with sharing experience with colleagues and everyone, to change the access challenges we met, avoid complication in order to achieve better outcome and less event for recovery in this challenging group of patients who were turned down for open surgery and they are high risk. It remains technically challenging, but as everything, it will become less and less in the future. And I'd like to thank you very much for listening.